Good afternoon, learned audience. I am Dr. Azfar Hossain Bhuiyan. My topic is when novel innovation makes complex PCI simple. Patient 65 years old lady, hypertensive diabetic, dyslipidemic, hypothyroidism and ESRD on mechanical hemodialysis, came to us with chest discomfort on exertion for few months. CCS class 3 and history of fall at home with a cut injury on the forehead. His hemodynamics was stable and GCS 15 and motor and sensory function was intact. This is the ECG. There is no specific changes in the ECG, and this is chest X-ray. And we did echo. There is no regional wall motion abnormality. Ejection fraction was 60%. Her tropi first sample was 157 and second sample was 387, and hemoglobin was 8.8, creatinine 7.21, urea 130, serum albumin 2.7, TSH 16.6, CRP 12.5 and D-dimer 630. And the CT brain shows mild subfalcine hemorrhage which resolved in the repeat CAG. And carotid duplex found mild diffuse atherosclerotic changes in the right carotid arteries. eGFR was 8 ml per minute per 1.73 meter square. And after stabilization, we went for angiogram. And left main was calcified and normal. LAD was type 4 vessel, diffuse calcified and has got 80 to 90% stenosis at its proximal and mid segments. Diagonal branches are small and osteal disease. And LCX is good size vessel, calcified and got 60 to 70% stenosis at its mid segment. OM2 is reasonable size vessel with mild disease. And RCA dominant vessel calcified and has 80 to 85% stenosis at its proximal and mid segments, followed by mild plaque at its distal segment. And the syntax score was 32. And what should be the next step? Points to be remembered that patient is ESRD, high bleeding risk and calcified coronaries. We opted for PCI to LAD and RCA. And left coronary was engaged with guide catheter EBO 3.5, 6 French. LAD wiring was done with Sion blue wire and LAD was pre-dilated with 2x215 NC balloon at 10 to 14 ATM. And after pre-dilatation, I was done. There is calcification in the LED. Calcified segment was dilated with IVL balloon 2.5 into 12 millimeter. IVL going on 2.5 into 12 millimeter. After IVL, IVA study showed calcified lesion is well prepared for stenting. There is crack in the calciums. And mid to proximal LED was stented with 2.5 into 38 millimeter DES at 12 ATM. Proximal LED stenting by 2.75 into 32 millimeter DES at 12 ATM, overlapping the previous stent. And post dilatation was done with 3 into 10 NC balloon at 12 to 18 ATM. And final angiogram showed LAD was well dilated with TME3 distal flow. This is the post-stenting IVAS study. The stent is well apposed. After that, PCI to LAD, patient was sent to CCU for stabilization, and immediately dialysis done. And after 4 days, patient becomes stable, and then we proceeded for PCI to RCA. RCA was engaged with guide catheter GR 3.5 in 6 French. RCA wiring was done by Sion Blue and pre-dilated with 2 into 15 NC balloon at 10 to 14 ATM. And after pre-dilatation, I was done. Calcified segment was well dilated with IVL balloon 2.5 into 12 millimeter. IVL going on. And after IVL, IVA study showed calcified area was well cracked. Lesion was stented with 3 into 34 millimeter DES at 12 to 14 ATM. And post-dilatation was done with 3.5 into 10 NC balloon at 14 to 22 ATM. And after post-dilatation, I was study done. Final angiogram showed RCA was well dilated and the previous LED stent is patent with TME3 distal flow. Patient received immediate dialysis after the procedure. She was discharged on 4th day. 6-month follow-up showed no symptom with improved quality of life. My take-home message is calcified lesion is always a challenge for the interventional cardiologist. Use of novel technologies make complex interventions easier. Imaging should be used to optimize good outcome. And proper planning is the key to a satisfactory result. I acknowledge my gratitude to my mentor, Professor Shahabuddin Talukdar sir, for giving me the opportunity to.
Thank you, Azfar Hossain Bhuiyan, for sharing your knowledge. Now the question and session. Any question for the audience?
Thank you, Dr. Azfar, for presenting a very nice case. You used all the new modalities of calcium management strategy like IVL, both the cases, and also maintain the stage PCI. So because patient is a lot of comorbidities.
Yeah.
My question: you use 2 stent in the LED. Why you leave the LED ostium few millimeter, at least 5 millimeter? Because you use 2 stent, you can easily cover the ostium 1 millimeter in the left-band, because left-band has no disease. So there is a nidus to restenosis is high in this case. Keep in mind, I think. I like to attack the comment from the Ashok sir and Pratap. about this.
So
Whether in this case it is better to leave or cover the ostium of the LED is better.
Yeah. So let me just start off by my thought process. Was the patient on dialysis prior to the procedure, or you did 2 dialysis after the procedure?
Yeah, both prior to procedure and after the dialysis.
So patient was a patient on hemodialysis?
Yeah.
Okay. See, we go to, each time you used a 2.5 millimeter IVL, you used IVUS, you ended up, let's take about the LED. See, when I was thinking with you, there are a few purposes of that IVUS when you use it. After nitro, firstly, you want to make sure of the vessel size. You want to know the extent of disease process, and believe you me, in such calcified vessels, I'm not there to decide the modality. I already know it in my mind. That is going to have a modality. And you want to see whether the disease extends up to the ostia, and therefore what is the real size of that ostia. And those are the things that I want to see. I'm not there to see calcium in such situations. That's pre-decided for me. So your landing zones is what you see. The length of the lesion is what you see, and the size of the vessel, because you're going to be guided by IVUS completely, not by those angiograms. You know, you said, I took a shot, it looks good, so I do an IVUS. Actually, it's the other way around. Your IVUS is the guidance all the time. Your angiography is the last shot. I hope you've understood my whole philosophy. So we don't want to see that angiogram prior to the IVUS. We actually say, now I've optimized it because there were areas on IVUS which were looking bad, not an angiogram. There are areas on IVUS which are looking bad, so I went in with instead of a 3, I went in with a 3.5. I actually went up, I looked at it with IVUS, now it was giving me better MSAs. So your final endpoints is not those angiograms, your final endpoints is the MSAs. I hope I'm making the philosophy of the sequence clear. The second aspect is that your IVL sizing, clearly for the right side, I mean the left side, maybe because you started distally, it was 2.5, and by the time you came back, it was actually 3.5 vessel. But in your right, you actually went a 3 stent, and then you did a 3.5. That means your IVL was grossly undersized. Now, the reason for saying that is that optimal size IVL is preferred. If you use a half size smaller IVL, as long as you're in contact with calcium, you will still do some fractures. But remember that IVL does not go through calcium indefinitely to the depth. If you stop the calcium, the waves earlier, which means on superficial calcium, then your deep calcium may not even get cracked with the 8 cycles that you have. So you really want to be optimally sized. You want to pre-dilate, you want to be optimally sized and deliver IVUS pulses, optimal sizing. And that's why you use IVUS, not for the sake of undersizing, but for the sake of optimal sizing. And that is why I have this objection. The third aspect important is, I don't again use IVL after, I don't use imaging after I've done IVL, and I'll show that to you why. For me, if I've done IVL, I may be able to expand with the balloon, whether fractures or no fractures. Because in the CAD study, so 30% of the patients and all had OCTs, 70% only showed fractures, 30% did not show fractures because those could be microfractures. Furthermore, all along the lens, you may not see fractures, but plates may get torn, which will still dilate. For me, it's the balloon dilatation with optimal size balloon, looking at it in 2 views, which tells you whether this lesion is going to expand after the IVL you did. Fractures can guide you, but are never going to be a surer way of knowing your lesion will expand. I hope that's clear. So yes. For me, if I was doing imaging, luckily OCT does not require, IVUS doesn't require contrast, but for OCT, I actually make sure I don't want to have those great looking images because I'm able to present that, but I want to pre, and I definitely want to post. And in between, I know my senses are good enough to tell me whether this lesion has had enough plaque modification.
Thank you, Dr. Azfar, for your brilliant case. But to Dr. Sheth, my question is, if there is disease in the ostium and keeping the stent 1 or 2 millimeter beyond the ostium, should we keep it? I think it is better to cover the ostium, and then we can give efficient pressure so that to post-dilate the lesion, stent.
Yeah, if you, at the ostia, if at the ostia, you had ostium of LAD, you had an area where you had an area which was greater than 4.5, I would just leave it.
Yes.
And stay away from the ostia. But if I did put in a stent, I would definitely want an area of greater than 6, close to 7 in that ostia. Then it would have to be a millimeter before the ostia, which means that if you by chance cover the circumflex and he has later a progression of disease into the circumflex, you're going to have a problem. So you're intelligent to stay away from the ostia, provided your proximal landing zone did not have a plaque burden of greater than 50% and that your ostia was greater than 4.5.
That's right.
Pratap, what about you?
I just wanted to tell you that we actually, Dr. Seth very clearly told one point, why we do an IVUS. IVUS is doing only to see the normal to normal vessel. If you don't see a normal to normal vessel, you have to land stent at a plaque less than 40%. That should be the point. And we did not get an idea where is your distal landing zone and proximal landing zone. Why people are asking, why did you put the stent into the ostium and all? If you are telling that the ostium does not have a plaque burden, less than, actually the plaque burden is less than 40%, you can, now tell that I am away from the ostium, I don't want to get into the LMC and leave the disease. But the second question I just want to tell you, you took an IVL, but the size was definitely undersized, wrong. If you take an IVL and in a patient with a own hemodialysis, you can do the RCA also at the same time with the same IVL, you can take 80 pulses you get. Why to buy another IVL on another day?
Patient developed LVF. That's why we postponed the.
I did not get.
LVF. Patient developed LVF after the.
That's the point. When you have an IVUS there, you should not give that much injections. That is actually one of the most important thing. When people will tell that only for non-dialyzed patients with a severe LV dysfunction, where also the avoidance of contrast is actually important to avoid LV dysfunction or a pulmonary edema patient on the table. That is also one advantage of doing a less contrast angioplasty.
Thank you. So, Azfar Hossain Bhuiyan.
So clearly optimization is not on an angiogram, it's on IVUS. Your final shot is the only one which everybody needs.
Thank you, sir.
Thank you.